Hello, my dear nursing aspirants. Welcome you all to the Master Nursing classes. In the last session, we have discussed most of the important things that is on the dose of the adrenaline in the adult anaphylactic reactions and dose of the adrenaline in the cardiac arrest and some very important research point where we have discussed what is a retrospective study, what is prospective study, what is Haworthorne effect, what is the attrition bias. Most important words that all you people have to know about the research where the repeated striking of the questions are there. So those things we have covered in the last session. Most importantly, nearly 50 plus concept I have explained that is most necessary for you all, right? So in the today's session also we are continuing the most important and high yield content that repeatedly striking in the exams. So all you people have to do is take a notebook, pen, make a note of it, and revise immediately after class and try to solve the MCQ on the particular session things what I'm explaining here today because it is most important. And here in today's class also we are go with the solving the one MCQ along with that all possible MCQs related to that concept. So we will deal with question plus concept that is our only key for success, right? Without wasting the time, we will start the today's class. Bacho, if anyone of you are watching the master nursing classes first time, so please do subscribe to the channel. And if you are watching master nursing classes videos on regular basis, and if it is helping you, so please hit the like button. Your one like, your one subscription matters a lot for us to build our community, right? If our videos coming from the master nursing classes are helpful for you all, so please do subscribe to and like to the session. So that is our request, right? We will start the today's class without wasting the time. And before starting the main class, here is the beautiful motivational quote for you all. What is that? Yes, I know. Study sucks, but believe me, trust me, not more than the failure does. बच्चों स्टडी करने से थोड़ा फ्रस्ट्रेशन हो जाते हैं, थोड़ा टेंशन हो जाते हैं. We have to sacrifice some things. It sucks our actual time and it sucks our actual energy also. But it not damages more than the failure. It is not dangerous as failure. Failure is more danger than the study. Okay, right? You study and come out of the failure zone and get the success. Right? So with this beautiful motivational quote, we will start the today's session that the with updated thing. So the thing is that is when we have to celebrate World Patient Safety Day. Okay, when we have to celebrate the World Patient Safety Day. World Patient Safety Day is celebrated on the 17th September of the every year. 17th September of the every year we have to celebrate the World Patient Safety Day. Okay, important, and the themes that will be asked in your exams. Okay, take a screenshot of this one or make a note of this one. Okay, World Patient Safety Day theme 2024 is improving the diagnosis for patient safety. And the most important, it's very important, that is the Patient Safety Day 2025 theme will be, yes, it will be safe care for every newborn and every child. Bachcho, this is most important, the theme of the 2025 for the patients World Patient Safety Day. Okay, so that is 2025 theme will be the safe care for every newborn and every child. So this is the theme for the our upcoming World Patient Safety Day. I am telling it's a very important. Take a screenshot or make a note of it. Okay. Yes. The next one is the what is the classical sign of the Gossypiboma? What is the classical sign of the Gossypiboma? First, tell me what is the Gossypiboma. Yes. The Gossypiboma is the very simple thing. Consider this is the patient who is sleeping on the OT table. Okay. The surgeon have done the surgery and he have accidentally missed one gauze piece inside the abdomen of the patient. So retention of the surgical items inside the body cavity. What we can say Gossypiboma is the retention of surgical instrument or any item, surgical item inside body cavity. So this is what you call as the Gossypiboma. Okay. So here is the gauze piece inside the abdominal cavity and the surgeon have closed the suture here. So this is what we call as the Gossypiboma. So what is the classical sign of the Gossypiboma? The Gossypiboma classical sign will be yes. Option A, the clear image of the foreign object. We can't directly see the clear image there. So the classical sign will be like this: the presence of the radio opaque markers or mass resembling a sponge. Okay. So this is the classical sign of the Gossypiboma. Okay. The sponge retention or any surgical item retention inside the body cavity is called as the Gossypiboma. The classical sign will be we have to see the radio opaque marker. Sir, how we have to see the radio opaque marker? Look at this one. So all of you seen this gauze pieces in your hospital. Focus here, bacho. Here there is one blue color line is there. Are you people able to see this blue color line? So this blue color line is a radio opaque line. Okay, this is the radio opaque line. Means if I keep this one inside the body, okay, and I will take X-ray, it will be clearly visible on X-ray, MRI, CT, okay, all imaginary methods we can clearly visible this one. So this is what we call as the radio opaque line. Very very important. So this many time question came that what is that blue line in the gauze piece indicates. Yes, blue line in the gauze piece indicates the radio opacity of that gauze piece. Okay, accidentally we kept the gauze piece inside the body. We can do X-ray. Okay, so we can do go for the CT. Okay, but most commonly the surgeons will use the CR machine. Okay, CR machine. CR machine will be there in the OT. It will give the real time image. Okay, so if we will keep the patient in the CR machine, so it will be like this. Okay, it will be like this C shape, and here will be one display. If we place the patient here, it will give the real time image. Okay, in this display. So this is the CR machine. Okay, so for the real time image, I will show this CR machine image based question in the next video. This is just for your idea purpose. I have drawn this one. Okay, so this one usually used to assess the any retention of the surgical material inside the abdomen. Okay, if any doubts. So when we will get the doubt, means as well as we know that surgical safety checklist, the last portion during the sign out means before sending the patient out of the OT, we have to check the count of the gauze piece, the count of the scissors we used, the count of the needles we used, everything we have to check there, right? If gauze piece we used 10 and in count only we are getting 9, so then we will get the doubt that one is retained inside, right? So it's very important to count the gauze piece and all surgical instrument we used for that surgery immediately after the procedure before sending the patient out of the our operative room. Okay, so wait, I will explain entire surgical safety checklist with updated guidelines, everything, so don't worry about that one. Okay, yes, so I hope the Gossypiboma is clear and the classical sign of the Gossypiboma is clear and the radio opaque line and its importance is clear and the real time image, that is the CM machine we have to use, this one is clear, right? And here is the beautiful advertisement for you all. As all of you know that our RRB date for the nursing superintendent exam is already released, and as we promised previously only that we will give the best quality test series for our RRB nursing superintendent exams. Yes, as per our promise, we have launched the RRB nursing superintendent exam test series in the name of the Vande Bharat test series for the RRB nursing superintendent. If you are interested and if you are a candidate who applied for the RRB exam, so please take use of this one. Okay, it will be a very helpful, and clearly we have mentioned the rationally, that is very high yield questions, selected questions, important questions, and the entire syllabus of the RRB is planned and covered in the only 30 test papers, including your anatomy, physiology, microbiology, nutrition, psychology, psychiatry. Everything will be covered before going to the exam in the question answer format and in the rational format. So you people will be very fit to answer for every questions in the exams if you are practicing the question papers from the master nursing classes. Okay, yes. So this will be a advertisement for you all, and this is our helpline number. Anytime you can WhatsApp to this, and we are having the Telegram groups, WhatsApp groups where the continuously aspirants will discuss their doubts and share the important notes, and in the continuously quizzes will be running in our Telegram groups. Okay, on all nursing subjects and non-nursing subject, and any information related to class, the class timing, everything you people will be get updated in our WhatsApp groups, Telegram groups. Okay, please do join to our this social media platforms, and so please do download the master nursing class app from the Play Store and enroll for the test series, right? So here is the next question. Yes, the sign out phase of the WHO surgical safety checklist is performed. Just only we have discussed this one, the sign out, when we have to perform the sign out. Yes, option A, before the patient put under the anesthesia, that is the before induction of the anesthesia is the first step, that is the sign in. Okay, this is what you call as the sign in, not sign out. During the surgery, we will not do anything. And after the surgery, before the patient leaves to the operating room. Okay, so this is the last step, we have to perform the sign out. And before taking the skin incision, we have to go for the time out. Okay, so the first step is the sign in, second step is the time out, and the third step is the sign out. Sir, how to remember this one? Remember with the mnemonic C to so. Okay, C to so, CTOSO. Okay, this is the sequence. Here we are doing the sign out before induction of the anesthesia, means that is the sign in. Before skin incision, that is the time out. And before patient leaves the operating room, that is the sign out. Okay, it's very important, bacho. The sign in is the first step, time out is the second step, sign out is the third step. Okay, the question will come like here, in which part of the surgical safety checklist we have to assess whether the site is marked for surgery or not. Yes, the site mark for surgery how to be assessed in the before induction of the anesthesia, in the sign in only. Okay, so in the sign in only we have to assess the whether the site mark is done or not. Why it is very important, bacho? Remember, the cases happen like this. Consider she is a female with a breast cancers. Okay, so here the tumor is there in the right breast, and doctor he didn't mark the site, and he didn't know that where the imaging are there or not, and he are going to take incision in the left breast, means it is very dangerous. The patient attenders will kill us, right? So that is the reason, before taking the patient to the OT, so inside the our pre-operative area only we have to mark the site. Okay, where is the actual surgery need to be performed. Okay, so that is main important thing. Okay, and this confusions will always will be there in the OT. Okay, like the patient will comes with a cataract. All people know cataract is associated with the age. So both eyes cataract will means bilateral cataract will be very common type of cataract. Okay. So if we are planning the cataract surgery for the right eye and the patient comes to the operative rooms, then the surgeon is getting confused. Both eyes are getting cataract, which eye to perform. Both eyes surgery we can't perform one time because it blocks, means after surgery we have to apply the bandage. If both eyes we are applying bandage, means patient can't able to see, means the cataract surgery, one eye surgery will be performed first. Then after some days, 15 to 20 days, again we have to call back the patient, and on the another side, I we have to perform the surgery. Okay, so that is the reason site marking is very important, right? Site marking should be done in the pre-operative area only. Means we have to confirm this one in the sign in only. Okay, we have to confirm this one in the sign in only because it is very important. Then the next is we have to check whether the patient is allergic to any kind of the medications. For example, for some local surgeries, we have to give the lignocaine local anesthesia. I think all of you have know this one. Okay, lignocaine as the local anesthesia. So if the patient is allergic to the lignocaine and you are giving the lignocaine to the patient, means patient may go into the anaphylactic shock. Okay, so as patient comes for a small surgery under local anesthesia and he is going to the shock, means it's very dangerous. So that is the reason before induction of the anesthesia we have to check for the any allergies are there for lignocaine or any allergies are there for antibiotics. It's very important, bacho. Okay, and is the anesthesia machine is working or not. So this one also most importantly we have to check in the our sign in. Okay, so before induction of the anesthesia, and whether the pulse oximeter is working or not, and whether it is working or not on the patient. Why? Because in India there is a system like if the patient coming to the hospitals, they will come with a nail polish. Yes, like they feel like they're coming to the functions, like they will come to the hospitals with a nail polish. If nail polish is there, our pulse oximeter will not work. So this is very important as a nursing officer. Before shifting the patient to the OT from the pre-operative to the intra-operative room, we have to check the nail of the patient and the nail polish should be removed. Then only the pulse oximeter will work. And if any discoloration will be there, we can see easily. So this is the reason there should be no nail polish on the nails of the patient while shifting from the intra-operative to the post-op. Sorry, from the pre-operative to the intra-operative area. Okay, so it's very important. And risk of the blood loss will be asked to the surgeon here only. Okay, it's very important. If risk of the blood loss will be more, so we have to preserve the blood. Okay, we have to keep the blood ready in the blood bank, then we have to go for the surgery. If there is more chance of the blood loss is there, surgeon started the surgery without reserving the blood. Now the excessive bleeding will be there, means we can't get the immediately blood. Blood is not like a paracetamol. We are going to the medical shop and we are asking and they are giving. It's not like that. So we have to cross match the thing where the patient sample should be sent priorly. The lab technicians in the blood bank, they will cross match the thing. They will keep the blood ready. If necessary, they will give and issue the blood immediately in emergency. Okay, that is the reason. So expected blood loss should be and risk of the blood loss should be assessed in the our sign in only. If more blood loss, we have to arrange the blood back priorly. Okay, it's very important, and all the important points we have discussed on the sign in, that is the before induction of the anesthesia. Okay, very important. First one is the whether site marking done or not, whether the pulse oximeter working or not, whether the this one anesthesia machine working or not. Okay, and any allergies to the patient and expected blood loss. Okay, so this one also, and any risk of the aspiration is there or not, that is also we have to assess here. Okay, so risk of the aspiration also we have to assess here. Very important. Then comes to the second one. The second step, all you people know that before skin incision, this is the what we call as the time out. Okay, so this is second step is in surgical safety checklist is the time out. So before the skin incision, we have to give we have to make sure that whether the antibiotic given or not. Okay, so the time duration they will repeatedly ask in the exam, has antibiotic prophylaxis given or not within the last 60 minutes. Yes, if it's not given, yes, we have to tick it yes. And the question will ask when we have to give the antibiotic prophylaxis before surgery, means just before 60 minutes surgery, or the range will be 30 minutes to 60 minutes. The single best answer will be we have to administer the antibiotic 60 minutes before the surgery. So this is the very important. Okay, And if in case the surgery is going more than 4 hours, the surgery duration means the surgeon started the surgery at the morning 10 a.m. and he is still doing surgery after 2 p.m. also, means 10 a.m., 11 a.m., 12 a.m., then 1 a.m., 2 p.m. means it's going more than 4 hours. So repeat the dose of the antibiotic. If the surgery is going more than 4 hours, so again need to repeat the dose of the antibiotic. It's very very important. Okay, bachcho, where we have to confirm whether the antibiotic is given or not means. So that is in the timeout we have to confirm whether antibiotic prophylaxis is given or not. Okay, it's important. And here the all team means the circulatory nurse will be there, the scrub nurse will be there, the assisting surgeon and main surgeon, and the anesthesiologist. So these many people will be there in the OT to operate one patient, right? So there, everyone have to explain their role. Yes, I am the circulatory nurse, I am the scrub nurse, I am the main surgeon. Yes, myself like this, I am the assistant surgeon, and myself like this, I am the anesthesiologist. Everyone should describe their role, and as a team coordination, they have to move on in the surgery. Otherwise, the surgeon don't know who is the scrub nurse. He is asking the needle for the circulatory nurse. Their circulatory nurse won't able to give the needle because she is not completely sterile there, right? So surgeon should know who is the scrub nurse. Then only it is very coordinately without any frustration the surgery will complete there. Okay, so that is the very important reason all description with name should be mentioned in the before taking the skin incision. Everyone should explain their roles there. Okay, it's very important. Then comes to the surgeon will assess any critical things are there with the patient, and anesthesiology will assess any critical thing there with the anesthesia. Okay, it's very very important. And as a nursing officer, we have the role here that if the patient any having the imaginaries like X-ray in orthopedic surgeries, X-ray should be must. Okay, we have to display X-ray. Then the orthopedician will look at the X-ray and he will do the procedure because he should know that where the fracture actually. Okay, and in some type of the laparoscopic surgery also the image should be there. Okay, so we have to display proper image and the surgeon should see that one and he will operate easily. Okay, so it is very very important. Then comes to the last one, that is the sign out. Okay, before patient leaves the operating room, before patient leaves the operating room, we have to go for the sign out. Okay, so here the nursing officer should check the count of the all instrument, sponge, needle and needle holder. Every instrument count should be done before shifting the patient out of the OT. Everything is okay, shift the patient out of the OT. If one thing is missing, then take the patient under the CM machine and check if the any needles, any sponge is there in the abdomen of the patient. Okay, so that is the very very important question. So this is the thing where we have to follow in sequence in the surgical safety checklist, and some few important rapid point revision will be there here on the surgical safety checklist. Okay, so take a note of this one. Yes, who given the surgical safety checklist? World Health Organization (WHO) given the surgical safety checklist. The three components of the surgical safety checklist is the sign in, time out, sign out. Okay, so there is no time in. Okay, so the question will come: which of the following is not a component of the surgical safety checklist? So there you people have to know that sign in will be there, time out will be there, sign out will be there, and time in is not a component of the surgical safety checklist. So this kind of the questions will come. And next, most important, when we have to perform the sign in, this is the before anesthesia. Okay, before anesthesia. This is before. This is also before. This is also before. Yes, it's easy to remember. This is the before anesthesia. This is the before skin incision. And this one is the before shifting patient out of post-operative area. Okay, so this will be the very important. The question will come. So which one you have to make sure that before shifting the patient out of the OT, that is the sign out. Okay, so this was the question which was asked in our here. Okay, so the sign out phase of the WHO surgical safety checklist. So which one will be performed? Okay, so that is correct answer. Already I have explained after the surgery. Okay, so this is after the timeout, means after the surgery and before the post operative, before shifting the patient out of the OT. Okay, that is the correct answer here. Look at the option, right? So after the surgery means after the sign out and before the patient leaves the operating room. So this one we have to check in the our sign out. It's very important and it will comes in the exam, right? I hope everything is clear on the surgical safety checklist. So then comes to the next question, and again very important question. But so we are dealing the that practical questions in the all complete this session, because as all of you know that AIMS is planned for the skill test and cancel. Why? Because they want to assess the practical skill of the patient in the prelims. And if the practically compatible candidates only, they will select the means. So this is the reason I am focusing here on the complete practical questions also. But even if you are having a heavy knowledge on the practical things, but a theory related practical thing you don't know, means you it's difficult to crack the exams. So I am giving you here my personal practical experience and standard experience, along with that theory related practical questions that will striking in the exams. So I am delivering that one. Okay, so the Gossypiboma also the practical related question, the surgical safety checklist, all practical related questions I have explained. And this is the next question. Okay, so the question is very simple. What is the primary purpose of the Mallampati score? Mallampati score in the clinical practice. What is the primary purpose of the Mallampati score in the clinical practice? Yes, try to give your answer in the comment box. Option A, to predict the easy or difficult tracheal intubation. Option B, to determine the patient's oxygen saturation. If I want to know the patient oxygen saturation, I will check with the pulse oximeter. Pulse oximeter will be there, so I will check with this one. So there is no need for the Mallampati score. So I am eliminating option B. Option C, to assess the risk of the deep vein thrombosis. So here I will go for the Virchow's triad. Okay, so the risk of the deep vein thrombosis will be assessed with the help of the Virchow's triad. Okay, so this is not a Mallampati score will not expresses the risk of the DVT. Okay, so option D, option C I am eliminating, and option D, to evaluate the patient's ability to undergo a surgery. So if the patient having ability to undergo surgery or not, it will be checked in the pre-anesthesia checklist. There is a PAC. So before inducing any anesthesia, there will be a format called as the pre-anesthesia checklist. So this one, the anesthesiologist will give fitness for the surgery. Before that one, the anesthesiologist will check all viral markers, that is HIV, HBV, HCV, any positive or negative. If the viral markers will negative, no problem. If the viral markers will positive, we have to take the extra precautions during the surgery. And the anesthesiologist will check the PT-INR values. If the PT-INR value is more, means there is high risk of the bleeding, the anesthesiologist will not give the fitness for the surgery, because the patient may die during the surgery because of the bleeding, right? So, and very importantly, consider one more point in your mind, that before any kind of the surgical incision, before 72 hours of the surgical incision, we have to stop all anticoagulants. If the patient on heparin, warfarin or anything, if he is posted for surgery after 72 hours, means now we have to stop the all anticoagulants, means before skin incision, before 72 hours we have to stop the our anticoagulants. It's very important, right? The examiner will ask the question repeatedly here. Okay, so the next one is the option D, to evaluate the patient ability to undergo. This will be decided by the PAC. That's the what I am telling, the pre-anesthesia checklist. There the anesthesiologist will check the viral markers, PTINR, and Mallampati score also he will check. How we will check with Mallampati score? So that is the like here. Okay. So this is what we call as the Mallampati score. The primary purpose is we have to check whether the intubation we can do easily or not. Okay. So the ET tube can be inserted easily or not. Okay. Before going to the classical explanation, just the general explanation, if people just tell me where I can insert here ET tube easily or not, and where I can insert here the ET tube easily or not. Yes, in the image first, so I can insert it tube easily, and I can insert my hand also easily because it's an open area here. Okay, right? Not my hand, just for the comedy purpose. I told. Okay, don't consider that point. Then you people will comment on that. Okay, so yes, in the class one of the Mallampati, our complete backside one, that is the soft palate and complete uvula, then complete hard palate will be visible along with the tonsillar pillars. So this is what you call as the tonsillar pillars. So both side complete tonsillar pillars, complete uvula, soft palate, hard palate, everything will be visible. So that is what we call as the class 1 Mallampati. It indicates easily we can intubate the patient, right? So then class 2 Mallampati is this one. Here we can see the soft palate also, the hard palate also, and uvula also. But the tonsillar pillars are not visible here. Okay, not visible. That is the tonsillar pillars we are unable to visible. Here also I can easily intubate the patient. Look at this one. In the Mallampati grade 3rd, only the base of the uvula is visible. Uvula base only visible and only hard palate is visible. So this one is the grade 3, and in the grade 4, bacho, only hard palate is visible, soft palate is completely not visible. Okay, so soft palate is completely not visible. So in the grade 3 and grade 4, it indicates difficult intubation, and grade first and second, which indicates the easy intubation. Okay, this is how we have to check the Mallampati score. If the patient is easily intubatable, means grade 1, grade 2, the anesthesiologist will approve for the surgery in the PSC checklist. If the Mallampati score is 3 or 4 grade, so that where the what we call anesthesiologist may postpone or withhold the surgery because of the difficult airway. Okay, so it is important, and the answer for this question is our option A, that is to predict the easy or difficult tracheal intubation. We have to go for the Mallampati scoring, and grades of the Mallampati scoring is very important. Bacho, in grade 1, complete soft palate, complete uvula, complete hard palate, and tonsillar pillars are visible. Grade 2, soft palate, uvula, and hard palate is visible. Tonsillar pillars and posterior pharynx will not visible. Then the grade 3, only base of the uvula will be visible, and there is no visible of the soft palate, and there is only hard palate will be visible. Okay, the base of the uvula and hard palate is visible, means that is the grade 3, and only hard palate is visible, no soft palate is visible, so that is what we call the grade 4. Okay, so this will be important for you all. And the next one is here. So what is the purpose of the zinc supplementation in children with the diarrhea? What is the purpose of the zinc supplementation in children with the diarrhea? Again, important question. Question will come, in a child with diarrhea, you are giving the ORS. Along with ORS, which element we have to give to the child? The question will come like this. That is the zinc is the element where we have to give to the child along with the ORS. So why we have to give the zinc? Why I will give iron? I will not give zinc. But your zinc is very important. Why? Because it decreases the severity of the diarrhea and it decreases the frequency of the diarrhea. So how the zinc is responsible for reducing the frequency and severity? Listen here. Look at the explanation. Bacho, this is our stomach, this is esophagus, this is the stomach, and this is our uh, first part of the duodenum, second part of the duodenum, third part of the duodenum, fourth part of the duodenum. This is jejunum and ileum here, right? So this is how our alimentary tract will be there. In the diarrhea, the epithelium of the our intestine is damaged. So this is the intestine and this is the intestinal epithelium. So in case of the diarrhea, this epithelium is damaged, means there will be irritation inside the intestine. So if the intestine is irritated, means the intestinal movement will increases. The intestinal movement will increases means the diarrhea frequency means the patient is going the 3 times means because of again irritation of the intestine he will go 4 times, okay, 5 times. So the intensity sorry frequency of the diarrhea is increasing. If the patient is going 3 4 5 times means there is highest chance of the electrolyte imbalance, means we the patient is going into the severe diarrhea. Okay, if in case I am giving the zinc, what the zinc will do, the zinc will repair the intestinal epithelium and it will be helpful for the re-epithelialization of the intestine. What it will be helpful for? Re-epithelialization. Okay, the epithelium it will get replaces. Okay, that is what we call the re-epithelialization of the intestine. So the intestines epithelium are replaced means there is no irritation. No irritation means the intestine movement will decreases. The intestinal movement will decrease means the frequency means the patient is going the 5 times, 4 times means the patient will go 1 time, 2 times because of the less irritation, less bowel movement. Okay, so the patient is going only 2 times, 1 time means there is less chance of the fluid and electrolyte imbalance means the severity of the diarrhea decreases. Okay, so this is the reason how the zinc is responsible for. Okay, so purpose of the zinc supplementation in children with the diarrhea means the only single and best answer. It decreases the frequency and it decreases the duration of the diarrhea. So it will be very very important and it will decreases the severity of the diarrhea. Option B is telling it will not decreases the sorry it increases the severity of the diarrhea. It's not correct. Then option C have no effect. It is having the effect. So I have explained which effect that is. Okay. So severe side effect, there is no severe side effect because it's on the immune booster. Zinc is the immune booster. Zinc is not having any dangerous side effect. Okay. So this will be the very, very important. So the main purpose of the zinc is to reduce the frequency, duration, and severity. Okay. If early the intestinal epithelium will get repair, means the duration. If the patient is having the diarrhea for 3, 4 days, 5 days, means it will close the diarrhea within the 2 days, 3 days. Okay, the duration of the diarrhea also will get decreases because of the early intestinal repair. Okay, so the now question comes here: the dose of zinc in diarrhea. Okay, consider it is in the dose of zinc in diarrhea. Okay, consider this one as in the very very important for our upcoming RRB exam and for our upcoming Norcet exam both. Okay, so how we have to divide the dose means if the child is less than 6 months, so the dose will be 10 mg of the zinc for the duration of the 14 days. Very very important. Less than 6 months child, 10 mg zinc for 14 days. In range, they can tell 10 to 14 days also, but the single best answer is the 14 days. If the child is more than 6 months, so our dose will be 20 mg of the zinc again for the 14 days. Very very important. But I am telling it's very important to take a screenshot of this one. Otherwise, make a notes of this one and revise repeatedly. It will help you. Okay. So here is the next question. What is the primary concern when using the morphine in pain management? So in the yesterday's last question, while explaining of the opioids used in the pancreatitis, and many coaching institutes they are telling that the morphine is the first and drug of choice, and some coaching institutes they are telling the mepiridine is the drug of choice. Today my class is coming late because of this question, and I want complete clarity on this one, so I have referred all new editions books that is there on the management of the pancreas, especially pharmacology. Why? Because I want to deliver up to date content. Okay, so whatever the conclusion I got from the book, from the nursing competitive book also, I will teach you here. Remember the points what I am telling, the situation what I am telling. Okay, so then choose your answer, because the drugs opiates in the pancreatitis depends on the what examiner actually asking is there. Okay, let me completely clear it for you all. Okay, so what is the primary concern when using the morphine for the pain management in the pancreatitis? The question is very important. We are giving the morphine to manage the pancreatitis pain. So, what concern we should have? The morphine is a opioid. It is having the specific side effects of contraction of the sphincter of the Ode. Sir, what is the sphincter of the Ode? Let me clear. So, look at this image. From here, this is the liver. This is the left part of the liver. This is the right part of the liver. Okay, from the left liver, the left hepatic duct is coming, and from the right side liver, right hepatic duct came, and left side liver, left hepatic duct came, and which is making the chyme and bile duct. I think this image is not clear. I will draw and tell you. Don't worry. The master is here. Don't have to fear. Okay. So this is the beautiful liver. Okay. This is the our left part of the liver, right part of the liver. Okay. From the left part of the liver, one duct will come, and from the right part of the liver, one duct will come. Okay. So this is the right hepatic duct, and this one is the left hepatic duct, right? So this both makes the common bile duct. This is what the common bile duct, and to the common bile duct our cystic duct will join. Okay, so what is the cystic duct? The duct which is coming from the gallbladder. Here is the organ, the small organ which is below the liver, we call this one as the gallbladder, right? So this one makes connection to the our pancreatic duct. Okay, this will be our pancreatic duct, and on this one there is organ which we call as a pancreas, like this organ what we call as the pancreas. Okay, so from here the stomach will be there, and this is the duodenum, right? So this is the stomach. Wait, students, I am explaining the thing, and I will explain the all questions which will coming from the anatomy from here, because it's important. So that is the reason I am explaining this one. Okay, right? This is the stomach, and this one is the duodenum. In the duodenum we are having the four parts. So this is the first part of the duodenum, this is the second part of the duodenum, this one is the third part of the duodenum. Again here will be extension will be there, the fourth part of the duodenum, then it will get converts to the jejunum. Okay, Bacho, the first question will come where the sphincter of Odi will open. So here this one is our pancreatic duct, which opening here. So this opening we call as in the sphincter of the Odi, and it is like a valve. So this is what we call the sphincter. So this opening is the sphincter of Odi. So if I am giving the morphine, it will contract this sphincter of Odi. So this sphincter of Odi is contracting means it's closed. Means whatever the enzyme which is producing inside, it is not coming out. Means the enzyme is overloading here. Again, the severity of the pancreas is increasing. Again, the damage to the pancreas is increasing. Right? While giving the morphine. So this is the reason morphine is contraindicated. Morphine is contraindicated in the pancreatitis. Yes or no? Yes, sir. Yes, sir. I will tell complete clarity, then it will give you a complete clarity to you after explaining the all questions, right? So, yes, this is the main what we call the concern while giving the morphine in the pancreatitis, that worsening of the pancreatitis happens, means pancreatitis will go more severe because of the sphincter of the Ode spasm, right? So, yes, sir, the morphine is having the side effect of the respiratory depression also. Yes, bacho, it is having the respiratory depression side effect also. Where we are while giving the morphine, we have to assess for the respiratory rate also, but it is not a primary concern in the pancreatitis. So repeatedly I was telling to control the negative marks also, bacho. What you know, that is no one wants. What examiner is asking, that is everyone wants. Okay. In question, the examiner asking the morphine in the pancreatitis, you have to go for the option B, because he is asking why the morphine is contraindicated in the pancreatitis. You are telling the respiratory depression. No, it's not a reason. Okay. So the reason he is asking. So our answer will be the option B is the correct here. Okay. So that is what repeatedly I am telling. Response to the question what examiner asking, and don't respond according to your knowledge. Okay. So that's for understanding is the very very important. Okay. So the question will come, right? And one more anatomical question will generate here. Okay. So that is what we call common bile duct is a combination of the right and left hepatic ducts. Okay, this one is very important question. And where the cystic duct will join? Cystic duct will join to the common bile duct. Where the cystic duct will join? The cystic duct will join to the common bile duct. Okay, if any stone in the cystic duct, so this is what we call as the Cholelithiasis. Okay, if the stone in the gallbladder, this is what we call the cholelithiasis. Okay, choleo means the stone. Lithosis means the stone. Okay, nephrolithiosis means the kidney stone. Same here, the cholelithiasis means in the gallbladder there is stone is there. Okay, if the stone is inside the cystic duct, we call that one as the choledocholithiasis. Okay, so in common bile duct also we can say choledocholithiasis. Okay, so it's an very very important, very very important words the examiner will throw in front of you people. Okay, so the next question, from where the bile will production happens? The bile production will happens from the liver. Means the next question is where the bile will store. The bile's juice will be stored in the our gallbladder. Okay, it will be stored in our gallbladder. Very very important. So this question also it will produce us. Okay, so and the next question is where the sphincter of Ode will open in which part of the duodenum? The sphincter of the Ode will be open in the second part of the duodenum. Okay, it will open in the second part of duodenum. Look at this one. This is the first part of the duodenum. From here the stomach will be there. Okay, so this is the first part, and this one is the second part. This is the third part. So it's opening in the second part of the duodenum. So this question also will be struck in the exams many times. Okay, so that is the reason I think the biliary system, this entire flow of the bile juice is called as the biliary system. Okay, so I have explained everything in the biliary system, and if people are fit to explain any question which comes in the RRB specially and in the Norcet also, it will be helpful. Okay, so is that clear, bachcho? Yes, it's clear. So let me go for the our main answer here. Okay, so opioids in the our pancreatitis. So if the examiner asking the question, always you people have to focus on the questions while answering the opioids in the pancreatitis. That if the examiner asking the question, the safest drug and opioid of the choice with the safest effect. So the first answer would be the fentanyl. So this one I have told you people yesterday. Okay, the safest drug or the opioid of the choice is the fentanyl. If this one is not in option, the second one is the hydromorphone. Okay, the second safest opioid to reduce the pain in the pancreatitis is the hydromorphones. Okay, so here morphine is causing the sphincter of Ode spasm, and this meperidine is causing the sphincter of Ode spasm plus a seizure. So if examiner asks the question which opioid is used to manage the pain in pancreatitis case, because it's very important. Bacho, it creates very dangerous pain where we can't tolerate that pain. Okay. So first priority is the yesterday I have explained, that is the fluid replacement and keeping the patient NPO with complete explanation I have explained in the last class. Okay, that is the priority in the pancreatitis case. The second priority is the pain management in the pancreatitis case. So the opioid where we are using is the going to matter a lot in the exam purpose of the view. Okay, the safest one is the fentanyl and second safest one is the hydromorphone is the second best answer. Okay, if these two options are not there in the answer, so if in case only morphine and mifedrine is there in the answer, then your best answer will be the morphine. Bacho, previously it was mifedrine, and as the studies recently which suggesting mifedrine is also causing the sphincter of spasm. Along with that, it is causing the neurotoxicity that it producing the seizures. Okay, as compared to this one, so this is the good. So I am going to choose this morphine as the answer now. Okay. Yes, the question is asking whether morphine is contraindicated or not. Yes, it's contraindicated. Mefloquine is not contraindicated or not. Yes, it's contraindicated. But the best one is the, as compared to mefloquine, morphine is the best one. As compared to morphine, fentanyl and hydromorphones are the best one. Okay, so this is the concept you have to keep in your mind while solving the opioids questions in your exams, right? So here is the next question for you all. Please do answer for these questions. Which of the following is most common surgical procedure performed in cancer located in the head of the pancreas? Okay, before going to the options, answers, so make sure that the one more question will solve here. Bachon, the most common site of the pancreatic cancer. Pancreas is like this. Okay, this is the head of the pancreas and this is the tail of the pancreas. Okay, so most common site of the pancreatic cancer is the head of the pancreas. Okay, so this is the most common site of the cancer of the pancreas. So which procedure we have to do, or the surgery name which will be done in the head of the pancreatic cancer? Option A, Whipple's procedure. Option B, partial gastrotomy. Option C, bariatric surgery. Option D, total gastrectomy. Okay, which one we have to choose the answer? Bacho, as I told, the pancreatic head will set in the duodenum like this. So this is the first part of the duodenum, second part of the duodenum, and third part of the duodenum, fourth part of the duodenum, right? So here the pancreas head will be set in the our second part of the duodenum. Okay, so in the surgery we are removing both pancreas also and duodenum also. So this is what we call as the pancreoduodenectomy. Okay, this is what we call as the pancreoduodenectomy. Okay, so the name of the surgery is called as the Whipple surgery. Okay, so Whipple's procedure. Very, very important questions. Very important. Sir, then what is partial gastrotomy, sir? What is bariatric surgery, sir? I will tell, don't worry. Bacho, what is bariatric surgery? I will explain you first. Consider, here is a Kittappa. His weight is like this one. His weight is 125 kg, you consider. So here, the patient will face many problems, like because of the excessive weight, his joints will get swollen. It will get to the arthritis, that is the osteoarthritis because of the excessive weight bearing. And his BMI is increased, means increased risk of the cardiac diseases, increased risk of the liver diseases, increased risk of the stroke will be there. So when heavy weightage patient, in order to reduce the weight, in order to reduce the weight, we will reduce the stomach capacity. We will reduce the stomach capacity. Consider this one is the stomach, and if I am putting band to the stomach, okay, like this. If I am putting band to this part of the stomach, means only this particular part of the stomach will be there. The patient will eat like half plate only. His stomach will get full, means the patient will not eat more. So the patient will eat less, means his weight will get reduces. So that is the reason where we have to do the bariatric surgery. Okay, bariatric surgery. The question which will comes on the bariatric surgery is what is the primary purpose? Primary purpose is to reduce the weight, reduce the body weight, by reducing stomach capacity. Okay, so this is what you call as the very important. Okay, in the bariatric surgery we have to reduce the weight by reducing the stomach capacity. So this is what you call as the bariatric surgery. I think all you people have clear on the bariatric surgery. Okay, so these are the techniques of the bariatric surgery. Okay, look at this one. This is most commonly performed one, and it's a reversible one, that is the adjustable gastric band. Okay, so here one port will come. Here one port will come. In this port, we have to push the air. Okay, so it will inflate the balloon here, and it will reduces the gastric capacity. Then the patient will eat less only, means the patient's stomach will get full here. Okay, so then after that, if you want, we can deflate this one. So this is what we call as the adjustable gastric band. It is important. Okay, the examiner given the image like this, like there is a stomach. Around the stomach there is a band with a what we can say, the adjustable port. So that is what we call the adjustable gastric band. Okay, so this will be done in the bariatric surgery. In some case we will cut a stomach like a sleeve. So that is what we call the vertically. Here they have taken the incision and they have separated the half portion of the stomach, and only half portion of the stomach is remaining here. So this is what we call the vertical sleeve gastrectomy. Okay, and sometimes complete stomach will be bypassed. Okay, the food will come into the our esophagus. From there it will directly go to the our what we call the intestine. So this is what we call the RAW-CNY gastric bypass surgery. Okay, that is the RYGB, RAW-NY gastric bypass surgery. Just all you people have to remember the name. Vertical sleeve gastrotomy performed in the bariatric surgery. RAW-NY gastric bypass surgery performed in the bariatric surgery. Adjustable gastric band, it will be performed in the bariatric surgery. So having the extra knowledge which makes always you to stand out of the crowd. Bacho, so standing out of the crowd which brings a perfect rank. If you get the perfect rank, then only you will be separated from the 1 lakh aspirants which are appearing in the Norcet 8 exams. Okay, so if you have extra knowledge, then you can choose the better answers in the all questions, and you will rank will be flowing in the top 20, top 30, top 50. So that will be helpful for you all. Okay, so these are the techniques performed in the bariatric surgery. Then I will come to the second point. There is the partial gastrotomy. There are the two techniques, Billroth 1, Billroth 2. So this was asked in the last previous exams, and this is the recently one questions in the what we can say INICET exam of the medical aspirants. So that where the chyme will mix with a pancreatic enzyme in Billroth 2 surgery. This type of the question will be there, and an option they have given duodenum, stomach, and jejunum. So let me clear this question with complete concept, so that will help you all. Okay, so what we say, this one is the partial gastrectomy means only half of the stomach we are cutting here. Means I call this one as the partial gastrectomy. If I am cutting complete stomach and I am eliminating the stomach there, means I will call this one as the complete gastrectomy. Okay, so Billroth 1 and Billroth 2 both are the partial gastrotomy. Okay, so partial gastrectomy, very importantly. So in the Billroth 1, what we are doing, look at this one, the distal part of the stomach is removed, and the duodenum, it will be fixed with stomach. So joining the two organ, we call the terminology here as the anastomosis. Okay, what is the meaning of the anastomosis? Anastomosis means we are joining the two loops, or we are joining the two organs, and we are making the suture. Okay, that is what we call the anastomosis. Means we are joining the two hollow organs. Okay, so that is what we call as the anastomosis, right? So here the duodenum is fixed with the stomach. Then the patient food will come. Okay, it will mix with the gastric juice, and just a second, please. Okay, the patient food will come and it will mix with the gastric juice, and it will comes to the duodenum in the form of the chyme. Okay, it will comes in the form of the chyme. Okay, so that is the very important. So if it is coming to the chyme, and as I told, the biliary ducts. Okay, the biliary ducts. Look at this one. This is the liver. Okay, and this is the right and left hepatic duct, common bile duct, pancreatic duct. It is coming to the duodenum. In the bilirubin one, the food we have taken and it is coming to the duodenum, and the pancreatic juice and the food which is mixing in the duodenum only, that is as normal as it. Okay, but in the bilirubin 2 surgery, so this is what we call as the bilirubin 2 surgery. So this one we call as the gastrojejunostomy. Okay, this one is the gastroduodenostomy, means we are creating an opening between the stomach and duodenum. That is the gastroduodenostomy. Bilirubin 2 also called as the gastrojejunostomy. Okay, so here what happening? We are connecting the particular jejunum to the our proximal part of the stomach. Okay, the food will come here. It will mix with the gastric juice, and directly food will comes to the jejunum. And from this side, okay, the bile juice will come, and it is coming to the duodenum, and it will mix with the food in the jejunum. Okay, so the food is coming this side, and the bile juice will come this side. The food plus bile juice mixed in a bilirubin 2 surgery in the jejunum. Okay, in the jejunum. Okay, so this will be the question they have asked in the recent exam. In the bilirubin one, it will mix it in the duodenum only. Okay, that is the very important. Okay, hope the concept is clear here. Okay, so these bilirubin 1, bilirubin 2 surgeries will be performed in the peptic ulcer diseases and some gastric cancer problem also. So that is very important for you all, right? So the next question is like here. One aspirant they commented in the our comment box of the last series, that is in the second class. Sir, please tell the adrenaline dose in the neonatal resuscitation also, because it's very important. Okay, so what is the recommended dose of the adrenaline or the epinephrine for a neonates in case of the persistent bradycardia during the resuscitation? Okay, so first all people have to tell when we have to give the adrenaline or the epinephrine in the neonatal resuscitation, means yes, make a clarity of this one. Okay, in persistent bradycardia only we have to give the adrenaline. Okay, first I will tell the basic. There is a normal fetal heart rate, sorry, normal neonatal heart rate you can consider. Okay, so that is around 120 to 160 beats per minute. Okay, this is the normal heart rate. If it is less than 120 and it is more than 100, then the primary nursing intervention is to stimulate the patient, just to stimulate the child. How we have to stimulate the child? The question will come. The techniques to stimulate the child is two techniques. One is rubbing the back. We have to take the child like this. We have to rub the back, gar like this. Okay. Then the child will get stimulated. The heart rate of the child will get increases. So the first very important thing, that is, if the heart rate is less than 120, more than 100, we have to stimulate the child. The first technique is rubbing the back. Then second technique is the tapping the sole. Okay, we have to take the sole of the child, means the foot of the child like this. Okay, this is the sole portion of the child. We have to tap like this. Okay, so this is what we call the tapping the sole. So very important two techniques to stimulate the child in the neonatal resuscitation. That is the rubbing the back, tapping the sole. Okay, very important. So this intervention will be tapping the sole. Okay, so this will be performed if the heart rate is less than 120, more than 100. If in case the heart rate is less than 100, then go with the bag mask ventilation. Okay, so this is what we call the bag mask ventilation, or we can say the positive pressure ventilation with the help of the bag mask ventilation. So what it indicates, here will be one bag will be there. Okay, for with to attach that one, there will be mask will be there. Okay, this instrument are you people seen in the your hospital? Yes, this bag mask ventilation is also called as the ambu bag. Okay, so what we also call this one? We call this one as in the ambo bag. Okay, if it is with the oxygen source with the extra bag, this one, so we call this one ambo bag with reservoir. Okay, here the oxygen supply will be there. So this is what we call the ambo bag with reservoir. So now the examiner will ask the full form of the ambo bag. That is the artificial manual breathing unit. So this is the full form of the ambo bag. Write it down once again. The artificial manual breathing unit, or the BMV, is the bag mask ventilation. Both are same. Okay, your bag is there, mask is there. With the help of this, we are giving the ventilation. So when we have to give the bag mask ventilation, if the heart rate is less than 100, more than 60, then we have to give the bag mask ventilation. Sir, we got this one. Sir, when we have to start the chest compression in the neonatal resuscitation, sir? Yes, that is also I will tell, don't worry. So, if in case the heart rate is less than 60 beats per minute, then start the chest compression. For the duration of the 30 second to 1 minute. If the heart rate is more than 60, then stop the chest compression. Okay, so then continue with the bag mask ventilation. Still, after 30 seconds also, after persistently you are giving the bag mask ventilation also, if the still heart rate is less than 60, so the next best step is our injection adrenaline. All possible questions I will discuss and deliver here, and we will rapidly revise everything that is necessary for our exams. Okay, Bacho, the first one question it will comes when you have to check the start the chest compression. If the heart rate is less than 60, then when you have to give the injection adrenaline. If persistently we are giving the back mask ventilation and chest compression, still heart rate is less than 60, then the last option we are having is the injection adrenaline or the injection epinephrine. Both are same. Okay, the both are same. Very, very important. So where is the question? Please just wait for a second. Yes. Yes. So here the persistent bradycardia, one word is there. That means we are giving the chest compression, still it is bradycardia. So that is the reason they have written here the persistent bradycardia during the resuscitation. Okay. So I hope it's clear to you. What is the recommended dose of the adrenaline in the neonates in case of the neonatal resuscitation? So the answer is here option E, 0.1 gram per kg per IV and IO. So this is not our correct answer. So the correct answer I will go directly. Okay, that is the 0.01 to 0.03 mg per kg is the correct answer. The best route and the first route is the intravenous. Okay, so take a rapid points here. So best and first route of the IV administration of the adrenaline is the in neonatal resuscitation is the IV. Okay, so which vein is the most preferred vein? So the umbilical vein is the most preferred vein. Okay, so which vein? That is the umbilical vein is the most preferred vein. So the examiner will ask how many centimeter we have to insert the umbilical vein catheter to reach the inferior vena cava. Bacho, here this is the abdomen. Here will be the umbilical. So just we have cut the what we call this one umbilical cord, and the vein is open only. So here it will connect to the inferior vena cava. So if we insert it 7 centimeter, if we insert it 7 centimeter, okay, so then it will reach into the inferior vena cava. Okay, the question which will came in the exam. Okay, so if you are inserting the 7 centimeter umbilical catheter, it will reach to the our umbilical inferior vena cava. So then if I am giving the epinephrine directly here, it will go to the inferior vena cava, from there to the heart. Okay, so the purpose is solved here. Okay, the purpose is clear here. So that is the reason the best and most preferred route of the administration of adrenaline in the neonatal resuscitation is the umbilical vein. Okay, IV route. If IV route is not possible, go for the intraosseous route through the bone marrow. Okay, the best site for the intraosseous route is the proximal tibia. Proximal tibia. So where we have to insert the intraosseous needle, we have to take a needle, we have to push the needle with force So the bone needle will go into the bone marrow. So directly we will inject the injection epinephrine or adrenaline in the bone marrow. The bone marrow is having the highest blood supply. It will suddenly absorb the blood. It suddenly absorbs the drug and it will take to the what we call to the heart easily. Okay, the second best route is the IO. If this is also not possible, the third best route is the endotracheal route. Okay, directly into the lungs we have to administer the epinephrine. So make a note of this one. Take a screenshot of this one. The first dose of the adrenaline is the best route. I have told already. IO first priority. Sorry, IV the first priority. IO is the second priority. The dose is 0.01 to 0.03 mg per kg of the epinephrine. So we have studied 0.1 to 0.3 mg per kg, sir. No. Bacho, this one we can write also as 0.1 to 0.3 ml per kg. So this is the thing which changing the answer. Okay. So 0.01 to 0.03 mg per kg, or we can say 0.01 to 0.1 to 0.3 ml per kg. Okay. So this will be very much helpful. Okay. Both are same. Sir, what is the dilution, sir? Always I told, if you are giving directly to the IV means dilution will be 1 is to 10,000 dilution. Sir, when we have to repeat the dose, sir, give the one dose. If heart rate is going more than 60, that is good. No need of the second dose. If heart rate is still less than 60, after 5 minutes, okay, after 3 to 5 minutes, the best answer is the after 5 minutes. Again, repeat the injection epinephrine. Okay, the question will come after how much duration we have to repeat the injection epinephrine. Option after 5 minutes we have to repeat the injection epinephrine. Very important. Okay, so that's the important thing. So then comes to the alternative route. We are having the endotracheal route. Here the 0.05 to 0.1 mg per kg. Okay, the dose here is the 0.05 to 0.1 mg per kg. So we can write this one here also 0.5 to 1 ml per kg. Both are same. Okay, so there is 0.5 to 1 ml per kg is the here the ml is the answer changing thing. Okay, so the dilution is the 1 is to 1000 here. Okay, so it's very important. Okay, so hope the concept is clear on the injection adrenaline in the what we can call in the neonatal resuscitation. It's very important. So now it's your choice. This is option A, this is option B, this is option C. So among these three, I want the answer which one is the open drain. Option A, option B, option C. So choose the answer. Which one is the open drain here? Yes, option A, option B, option C. Three options are there. I want the answer. Which one is the open drain? Yes, the open drain is the option C. This drain name is the corrugated drain. Okay, so this is the corrugated drain. It is not having any closed system. It is like just open like pipe only. If we will insert this one in the surgical site, if any secretion inside the surgical site, it will comes out. Okay, so this is the open drain. That is the corrugated drain is the open drain. Very importantly. And these two, option A and option B, are the closed drain. Okay, so these are the closed drain. So this is the closed drain with negative pressure, where we have to compress our Romovac and we have to fix. It will suck the any fluid which is generating inside the surgical site. Okay, so this is the closed drain with negative pressure, and this is the closed drain with no any negative pressure. It's normal pressure. Okay, so the option A, the name of the option A is the Hemovac drain. Hemo means blood. Vac means it's creating the pressure. Okay, or we can say the with the brand name, that is the Romovac drain. Both are same. Hemovac, Romovac, both are same. Okay, and this one is the JP drain. That is the junction pot drain. So all these three images are very important. It will come in your exams. Okay, it will come into your exams definitely. So the next question is, what is the recommended duration of hand washing with soap and water according to the WHO guidelines? Important. It's very important. Option is 10 second. It will be nowhere used, so I'm eliminating. Option B is the 3 to 5 minutes. This is the best time for the surgical hand washing. Okay, for the surgical hand washing or the surgical hand rub, the best time is the 3 to 5 minutes. Sir, I want only single best answer. That is the 5 minutes is the single best answer. Okay, so that is the 5 minutes is the single best answer. And 20 to 30 second, this is used for the alcohol based hand rub. Okay, alcohol based hand rub. And 40 to 60 second with the soap plus water hand washing. Okay, not hand rub, it's a hand washing. Okay, very very important. So in question what they have asked, they have asked for the duration of the hand washing. So that's the 40 to 60 second. This is our correct answer. Okay, so I'm highlighting option D. This is the correct answer, right? And option B is the for the surgical hand washing, and option C is for the alcohol based hand rub. So quickly revise the frequently asked question on the hand washing. Which one is the most important factor in the hand washing? So while washing the hand, which one is the most important factor? Which one is the most important factor? The friction is the most important factor. In options, they will give the soap, the water, the antiseptic solution, and friction. The most important one is the friction. Okay. So even if you are applying water and antiseptic solution, if you are not maintaining friction, means the hand wash is not completed. Okay. The friction is the most important thing. Okay. Very, very important. So which one is the preferred mode of hand washing at the site or the point of the care? Point of the care. So which one is the preferred mode of the hand washing? What it means for point of the care? It's very simple. You are giving a care at the bedside. Okay. So here which one is very preferred? In some private hospitals and in few government hospitals, all people I think has seen at attached to the this part of the bed. Here will be the they will keep a bottle that is the alcoholic based hand rub. Okay. So at the site of the or at the point of the care, the best mode of the hand washing is the our alcohol based hand rub. Okay. So this is the very important question, and this one is also called as the routine base of hand hygiene. Okay. Routine base of hand hygiene is the alcohol based hand rub. Okay. So when we have to go for the hand washing, sir, when your hands visibly contaminated, when your hands are visibly contaminated means if something blood, if something anything fluid, if some exposures which is visibly present in our hand, so then go for the hand washing. If there is no any visible contamination, no visible contamination means alcohol based hand rub is the preferred mode. If hands are visibly contaminated means we have to go for the yes, that is the hand washing with soap plus water. Okay. So if I am doing any surgical and sterile procedure in OT means we have to go for the surgical scrubbing. Okay, we have to go for the surgical scrubbing. Very very important. So the question will comes in your exams, right? Is the most important aspect of hand washing is the friction. The duration of the soap and water we have discussed, that is the 40 to 60 second, and the duration of the alcohol based hand rub we discussed, that is the 20 to 30 second, and duration of the surgical hand washing we have discussed, that is the 3 to 5 minutes. Among those, the 5 minutes is the single best answer. Already I have discussed, and yes, I think wise everything is clear, right? Yes. So routine method of the hand hygiene, I have told that is the routine method of the hand hygiene is the our alcohol based hand rub here, and at the point of the care or at the site of the care, best is the alcohol based hand rub, or routine base or the routine method of the hand hygiene is the alcohol based hand rub. Okay. So the next question will be like this. Okay. So choose the answer. What is the most effective? What is the most effective method for drying the hands after the washing? So you have done the hand washing. Which one is the most effective method of the drying the hands? Many of you people will wash the hands and you people will dry the hands like this, right? Option D is telling like this only. Check it out. So rubbing the hands to the cloth. Okay, we'll rub your hands to your own cloth. So this is a very third class practice. Okay, so we will not encourage this one. So option C is using the cloth towel. Okay, so this is outdated. Previously, we used to use this one only. Now it's the outdated. We will not use this one. So air drying. If you are going to the restaurant for having the food means air drying is okay. For in the area of the hospital, air is already contaminated. We will not encourage for the air drying. So option B, the using disposable paper towel is the preferred method of the drying the hand after washing the hand. Okay, so using the disposable paper towel will be the best answer. This is in the hand washing. I am not telling in the surgical scrub. Bacho, in the surgical scrub where we have to use the sterile towel. Okay, so that will comes from the autoclave department, CDSD, that is the central department for the sterile supply. So from that department, they will send the sterile towel. So the surgeon will wash the hand and he will dry the hand with the sterile towel. So not with the disposable towel. Okay, the disposable paper towel is in the hand washing, not in the hand scrubbing. Okay, very very importantly, all people have to know this one. So here is the next question. We'll ask that one only. So what complete after completing the surgical hand washing? How should hand be dried? Okay, so in the last question, this is just how we have to dry the hand in the washing, means the medical hand washing. This one in the medical hand washing with the disposable towel. In the surgical hand washing, if the examiner asking, the first option only will give with the disposable towel and all people will choose that one. You will not focus over the word the surgery. So the surgical hand washing where the surgeon should dry his hand with the, yes, sterile towel. Okay, with the sterile towel will be your answer here. Okay, hope the concept is clear and it's everything over the what we have discussed on the hand washing. All rapid revision points are clear. Okay, so there is one more point that is practical based. Okay, consider this is the hand, this is the elbow, this is the elbow, and this one is the hand. Okay, in medical hand wash, bacho, we have to always go for the less contaminated to more contaminated in the all aseptic procedures. Whatever the aseptic procedures we are doing, like whatever it may be, we are have to go always from the less contaminated to the more contaminated, right? So in the medical hand wash, in the medical hand wash, the elbow is sorry, the elbow is less contaminated and the hand is more contaminated. So the question will come, how the flow of water will be there? The flow of water will be there in the this direction, from the less contaminated to the more contaminated. Because if this more contaminated coming this side means it will again our like it will again contaminates the hand. So that is the reason we will not go for this direction. We have to go for the less contaminated to the more contaminated direction. From the elbow to the till the palms, we have to go for the medical hand washing. But its update will coming that update will tell that from the wrist to the fingers is the direction of the water flow in the medical hand wash. Okay, from the wrist to the fingers, here the palms are considered contaminated as compared to the wrist in the medical hand washing. Okay, so while washing the hand, the we have to keep it below the like the flow will be in the low direction. Okay, so hand will be in the low direction. After washing hand also we can keep it below the waist level in the medical hand washing. Okay, but it is not like this in the surgical hand washing. Okay, in the surgical hand washing, this is the hand, this is the elbow. Okay, and this is the beautiful hand of the nursing officer. Okay, here this particular point is considered as a less contaminated, means the palm is considered as a less contaminated and elbow is considered as the more contaminated, means the flow of water should be like in this direction from the less contaminated to the more contaminated in the surgical hand scrubbing. Okay, very important. And after doing the surgical hand scrubbing, we have to hold the hand above the waist level only, because the only above the waist level is considered as the sterile, and below the waist level is considered as the non-sterile thing. Okay, always hold the hand above the waist level in your all surgical procedures where you are performing as a scrub nurse. Okay, very importantly. Okay, so this is the all concept what we have delivered in the today's class. Bacho, the class duration are going more because as all of you know that the exam is very near. I want to cover all the important points that is repeatedly striking in the exam, whether it may be a simple point, whether it may be a complicated point, whether it may be an updated point, whether it may be a point that creating the confusion after reading the books. Okay, so all those points I will cover. Don't have to worry. Watch the classes completely. Take a note of the class. Okay, rapidly revise immediately after the class. That will help you people definitely. Okay, because many people, you people are having the confusion like in the dose of the adrenaline, what we have to give. Okay, so like mg per kg, ml per kg, people will get confused. I know that is common in the students' life. Okay, so once the clarity will comes from the master, there is no confusion. Okay, so this is the specialty of the master nursing classes. Okay, we have explained everything in detail completely. So hope everything is clear to you people, and we will meet in the next session. Don't miss the next session also. I am bringing all updated contents again in the next session with repeatedly asked question, and the most of the thing what you people definitely have to follow that content I am uh, covering here. Okay, and many people you are commented that to conduct the two classes, but so it's like it's difficult for me. That's what I will cover the content which will be covered in the two classes in the one content. I am not making a video for the short 30 minutes, 20 minutes for the view purpose. I want to deliver the high yield content, and my students, my aspirants who are following me should be selected in the get selected in the selection list. So that is the my purpose. So if any one of you are get selected means I my purpose is solved. Okay, so nowhere you people will get the content like this without wasting the time covering the important thing that is necessary for exams. Okay, so if anyone is watching the master nursing classes first time, so please do subscribe to our channel. And if you love the class, if you love the content what we have given, so please hit the like button. And if you are any kind of the aspirants from any state, whether it may be Karnataka, Maharashtra, Andhra Pradesh, Telangana, Tamil Nadu, Kerala, okay, Rajasthan, UP, Bihar, Jammu Kashmir, from wherever you are watching the class, so please do mention your state in the our comment box, so it will help us from where till where we have reached. Okay, so just for the assessment purpose I am asking. Okay, just say love from Karnataka, love from Maharashtra, love from Jammu and Kashmir, like. Okay, so I am expecting your response in the comment box, and if any doubts you people are having, so please do mention in the comment box. We'll meet in next session. Thank you so much. We will meet again. तब तक के लिए जय हिंद, जय भारत. Don't forget to follow our Telegram group because quizzes are going there, and WhatsApp group because the questions are discussing there. Right? We'll meet again. And if you want, so you can purchase our test series, which is test series for the rank deciding. Okay? So we'll meet again. तब तक के लिए जय हिंद, जय भारत. Bye bye. Take care and take care of your health also because it's very important during the exam time. Okay? We'll meet again. Bye bye.